Welcome to this evening's webinar, Exploring Syringomyelia, Spinal CSF Disorder, and Adult and Pediatric Scoliosis, Understanding, Diagnosis, and Treatment. My name is Serena, your RICGP representative for this evening. We are joined by our presenters, Professor Marcus Dooley and Dr. Brian Xu, and GP facilitator, Dr. Natasha Fingo. Before we get started, I would like to make an acknowledgement of country. We recognize the traditional custodian of the land and sea on which we live and work, and we pay our respects to elders past, present, and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. I would like to introduce you to our presenter for this evening. Marcus is an Australian and international trained neurosurgeon with expertise in neurovascular surgery and disorder of CSF based at Macquarie University. After completing his neurosurgery training in Australia, he continued with subspecialty training in vascular neurosurgery at Stanford University and the University of Chicago in the United States. Brian is an adult and pediatric spine surgeon based in Sydney. Following his orthopedic training, he spent 18 months in the USA, completing further specialized training in all facets of spine surgery. Dr. Xu's area of interest is in all aspects of spine surgery and spinal disorders. Also joined is Natasha, a GP from Sydney who has moved to Gold Coast and works for a specialized women's health clinic where she has specialty interests in chronic disease management. She is committed to quality medical education of junior doctors and worked for many years as a lecturer at University of Notre Dame School of Medicine. Welcome to all presenters. I will now pass it over to Natasha, who will go over the learning objectives.
Thank you so much. And thank you so much to everyone for joining us today. I'll just quickly go through our learning objectives, which there are a few. Number one, we'd like to analyze the various types of syringomyelia. I had to learn how to say that tonight. That's the most important thing. Specifically, the clinical features and the treatment options. We will discuss spontaneous intracranial hypotension related to spinal CSF leaks, related to clinical features and treatment options. We'll also describe how to diagnose scoliosis in both adult and pediatric patients by identifying key clinical indicators and interpreting radiographic findings. Finally, we'll also discuss the management options available for adult and pediatric scoliosis. Our first presenter is Professor Marcus Dooley, who I didn't mention this before, but Marcus, you actually operated on my best friend's daughter and has completely changed her life for the better. So I'm very privileged to have to be sharing the webinar space with you today, and I'll let you take it away.
Okay, can you stop sharing the slides, please, Serena? And there we go. Right, so thanks very much, Natasha. It's a pleasure to be with you all tonight. I don't have any conflicts of interest to disclose. So I'll go through a little bit of quick CSF physiology and then some of the clinical problems associated with spinal CSF abnormalities. And of course, with CSF physiology, we need to think about where it's produced, where it's absorbed, and how it circulates around the spine. So you probably all remember from medical school that CSF is produced in the choroid plexus, goes down through the third ventricle, out the aqueduct, into the fourth ventricle, and out into the spinal subarachnoid space. And then it circulates around and gets reabsorbed back into the venous sinuses. It turns out that's not actually completely true. And the best model we have at the moment of this physiology is that if we think about the brain fluid compartments as the brain, the subarachnoid space, and then the vasculature and lymphatics, CSF is basically produced everywhere and it's absorbed everywhere. So it's really much more complicated than we were taught at medical school. And this is a good example of that. This is a patient who had a spinal injury and he ended up having post-traumatic syringomyelia. That's a very large syrinx involving the spinal cord. And at operation, there had been a complete transection of the dura. And so the dura was healed above and below. They were completely separate. But the CSF in the subarachnoid space and the lumbar spine was completely normal. And I treated this patient by joining those CSF spaces together. So clearly CSF is being produced in the lumbar spine and circulating there, and it's being reabsorbed there. And just as we know about CSF being absorbed into the venous sinuses in the brain, similarly in the spine, the pathway for CSF absorption is into little veins that attach to the spinal nerve roots. And there are also lymphatic pathways that are emerging as being important as well for the reabsorption of CSF. So it's a lot more complicated than we used to think. When you think about CSF circulation, you'll often see this kind of diagram where there's this complex stuff of what's happening in the head, and then they just show the top of the spine, and so CSF goes down into the spine and then back up somehow. The reality, of course, is it's a lot more different than that, a lot more complicated. So here's some computational modeling, looking at the effect of all the nerve roots, the arachnoid strands, the dentate ligaments, and how CSF circulates through the spine is very complicated. But we can see that now with our modern imaging studies, where we look at these dynamic MRIs that can show the subarachnoid space, abnormalities in the subarachnoid space very well. And they give us some indication of what's happening with the CSF in the spine. This lowest one is an intraoperative ultrasound showing some of the arachnoid strands and just how dynamic the motion of CSF and arachnoid is with each cardiac cycle. You may be aware of what's being called the glymphatic circulation, where in the brain and supposedly the spinal cord, CSF goes from the subarachnoid space into the brain or spinal cord around arteries, washes through the brain, takes out all the metabolites and other substances, and washes out around the veins. And that the proponents of this hypothesis would have you believe that this fluid flow is just washing out the brain and spinal cord substance. Well, my group's done a lot of research on this over the last 20 or more years and shown that that's actually not the case in the spine. That's, yes, CSF goes into the spinal cord from the subarachnoid space around blood vessels. And if there's any abnormality constricting the subarachnoid space, the flow of CSF into the spinal cord is actually increased. And so we're developing an understanding of how that might work. But I don't want to go into this into any great detail, but we have shown pretty convincingly that the CSF flow in and out of the spinal cord is definitely not as that glymphatic circulation would have you believe. The CSF is going in and out around all the blood vessels. So that was really just a bit of a taste of one of my research interests. So I'll get on now to the clinical information. So I'll start with Chiari malformation and Syringomyelia. And Chiari malformation is depicted here in this diagram as herniation of the cerebellar tonsils through the foramen magnum. And in this case, showing the cerebellar tonsil reaching to the C1 level. And what happens is that obstructs CSF movement between the head and the spine. And for reasons we still don't fully understand, we get CSF accumulating inside the spinal cord, and that's Syringomyelia. So yeah, in most cases of Chiari malformation, the syrinx is actually really quite separate from the fourth ventricle. I'll just go back to this diagram. So that's the fourth ventricle. That is the central canal, the normal channel down the middle of the spinal cord. And one possible way that CSF could get into the spinal cord is if it comes from the fourth ventricle into the spinal cord and expands the central canal. And in most cases of Syringomyelia, that's not what happens. So there are some rare cases where that's what happens. So there is the central canal, there's a syrinx that's communicating. But most of them are really quite separate. So there's no communication here between this syrinx and the fourth ventricle. And so how the CSF gets into the spinal cord is actually still a bit of a mystery. But those where it's communicating, so the syrinx forms close to the fourth ventricle, what we actually find at surgery is that there's a membrane across the foramen of Magendie blocking the CSF outflow from the fourth ventricle. And so it ends up being forced into the spinal cord. And the treatment there is to open up the fourth ventricle outlets. And if we do that, posterior fossa decompression, with or without opening up the fourth ventricle, we'll usually get collapse of the syrinx. Just like Chiari malformation, there are other conditions that cause obstruction of CSF flow at the craniocervical junction. And an example is arachnoiditis. So this is a patient who's got some scarring here that developed as a result of birth-related hemorrhage at the craniocervical junction. And that's caused a big syrinx. At operation, what we find is this real scar a band of scar tissue across the craniocervical junction, blocking the flow of CSF from the fourth ventricle down into the spine. And we can overcome that by putting in a small shunt from the fourth ventricle into the spine. And that causes collapse. So here's the shunt from the fourth ventricle into the spinal subarachnoid space, and the syrinx collapses. But not all syrinxes are like that. So this is a patient who does not have Chiari malformation. And this dynamic MRI, I think, illustrates just really how impressively dynamic this condition actually is. And that's important to think about, because if we think about medical school days again, you probably would have been taught that Syringomyelia looks like this, which is a post-mortem specimen. It shows that the spinal cord has collapsed. And it might make you think that a syrinx is actually some kind of cavitation or passive process, whereas pretty clearly not. So that's a very active abnormality there. And what we're also taught at medical school then is that cavitation, or that process inside the spinal cord, damages the center of the spinal cord, and it disrupts the crossing spinothalamic fibers, which are the fibers that carry the pain and temperature sensation. And it was thought that that is what resulted in the classical clinical presentation of Syringomyelia, which is this suspended cape-like distribution of dissociated sensory loss. And what's meant by that is that a person would have loss of pain and temperature, but not loss of light touch, because light touch is carried in the dorsal columns and is not disrupted by a syrinx or other abnormality in the middle of the spinal cord. Well, it turns out that's not exactly true. So in those cases where it's expansion of the central canal, they'll usually not have any clinical manifestations of that. It's only when the syrinx bursts through the central canal, or in those cases where it starts outside the central canal, that a person gets neurological problems. So in an example where the syrinx causes damage into the dorsal horn, yes, the person would get disruption of the spinothalamic fibers, and they'll lose pain and temperature. But if the disruption is into other sensory pathways or even into motor pathways, that might not cause any overt sensory loss, but there could be an imbalance in the spinal musculature, and that's what leads to scoliosis. And you'll hear more about that from Brian. So here's an example where very large syrinx, no neurological deficits because it's just expansion of the central canal. Here is where it has burst through the central canal and is causing damage to the spinal cord. And so that will cause a neurological deficit, as would that little one there. So it's not that part of the syrinx that's the problem, it's that small part. As I said, the syrinx can be associated with Chiari malformation. But if we treat the Chiari malformation here with a posterior fossa decompression, create CSF space around the cerebellar tonsils, the syrinx will collapse. Syringomyelia can also be associated with a tumor. And so here's a person with an intramedullary tumor inside the spinal cord, but not presenting directly because of the tumor, presenting because of the damage in the spinal cord caused by the syrinx. And if we remove the tumor, which we can do really quite safely for many of these tumors, here's the spinal cord opened up, the tumor's removed, the syrinx goes away, and that person has no residual neurological deficits. It can be from spinal cord injury where there's scarring in the subarachnoid space, again causes a syrinx. So here's a person early after spinal cord injury, a year later has this very large syrinx inside the spinal cord. And we can treat those patients by clearing out the scar tissue and allowing CSF to flow in the subarachnoid space, and the syrinx collapses. But sometimes we're not really sure what the cause of the syrinx is. So we might have a case like this where there's not really any clear abnormality on a normal MRI scan. And we can do some fancy scans looking at fluid flow. This is called a phase contrast MRI, where it depicts fluid flow in the subarachnoid space, but difficult to interpret. And an MRI with T1 weighted is almost impossible to see any abnormality in the subarachnoid space. So we use these new dynamic techniques now that demonstrate pretty clearly that the abnormality in this case, and I'm hoping that's shown clearly, is an arachnoid membrane. So this is congenital membrane, which is just a bit thicker than normal and completely obstructing the dorsal subarachnoid space. And that's the cause of the syrinx in that patient. And at operation, that's the spinal cord. Here is that congenital arachnoid band. We see them very clearly on intraoperative ultrasound. So that's the syrinx inside the spinal cord. That's the arachnoid band. And cutting the arachnoid band is usually sufficient to make the syrinx go away. So that was just a quick run through of syringomyelia, and just to reiterate that there are those that are inside the central canal that don't cause neurological deficits. There are those that either burst through the central canal and damage the spinal cord, or sometimes they start outside the central canal, and they're the ones that present with deficits. And I've shown you the anatomical basis for the clinical presentation. I'll just go through now some other spinal subarachnoid disorders. I mentioned the arachnoid membranes. So here's that case with the arachnoid membrane presenting with a syrinx cavity. This one was not so clear. This was thought by outside radiologists to represent a tumor. This was thought to be a complex tumor inside the spinal cord. But with our scans at Macquarie, we were able to show that there is this arachnoid membrane. And that's not a tumor at all. That's a syrinx, just a little bit complicated because of some of the internal structures of that syrinx cavity, but the underlying problem is actually that arachnoid membrane. And again, at operation, you can see the arachnoid membrane pretty clearly, and it separates the subarachnoid space from above and below. And for reasons we still don't fully understand, that's what causes a syrinx. And sometimes for these cases, we'll also put in a shunt. So here I've opened into the spinal cord, and I'm putting in a shunt tube that drains the syrinx cavity into the spinal subarachnoid space. So it doesn't drain it outside the spine, just gets the CSF to flow from inside the spinal cord back into the subarachnoid space. And that's the postoperative scan, so complete resolution of that syrinx and arachnoid membrane. But it can get more complicated than that. So here's a patient has a type of osteogenesis imperfecta, and he had a spontaneous spinal subarachnoid hemorrhage. And at the time, he recovered pretty well, but then a year or so later, presented because the scarring that had come from the hemorrhage around the spinal cord resulted in obstruction of the CSF flow in the subarachnoid space and caused a syrinx. So here's the distortion of the spinal cord caused by that scarring around the syrinx, and he presented because of damage to the spinal cord from the syrinx cavity here. And this was actually a really instructive case for me because I operated where I thought all the scarring was. I put a syrinx shunt in, but the syrinx actually got bigger rather than smaller. And it wasn't until I had to reoperate and found that there was more scarring further down that I was able to get resolution of that syrinx cavity. So even with our fairly sophisticated scanning techniques, it can be very difficult to tell where the arachnoid pathology is. And sometimes we never find it. So here's a person presenting with a syrinx, but there is presumably something affecting the subarachnoid space, but because the spinal cord is completely expanded, our imaging can't really demonstrate the subarachnoid space. So we can't tell whether there's any subarachnoid abnormality. And in fact, at operation, there was no evident abnormality. And with a shunt, the syrinx collapsed. And I would still have to classify that as what we'd call idiopathic, meaning we don't understand what causes it. But I'm sure that over time, as our imaging techniques improve, we will find the underlying cause for these patients. And this is just showing that sometimes patients can have more than one syrinx cavity related to arachnoid pathology. So this patient has got an arachnoid band here in the thoracic spine causing that syrinx, but also a second syrinx cavity in the cervical spine. And if I've operated here, corrected the subarachnoid space abnormality, put in a shunt, and both syrinx cavities go away. So the fluid inside the spinal cord is communicating, and just draining one of the syrinx cavities results in resolution of both. Sometimes, though, the arachnoid pathology can be too complicated. And this is another patient who had a subarachnoid hemorrhage. This time it was a cranial subarachnoid hemorrhage from the posterior circulation. The blood is tracked all the way down the spine, caused this extensive scarring in the spinal subarachnoid space, and then caused edema and syrinx formation. So the underlying problem was actually the hemorrhage causing the subarachnoid scarring. And that's almost impossible to treat. And this is another extreme example. So all of this spinal cord abnormality, all these loculations related to scar tissue, this is all related to hemorrhage. Sometimes they're caused by the old types of myelograms that were oil-based. They haven't been used for about 40 years, so it's only older patients who've had myelograms before the mid-1980s. They had scarring developed from the oil-based myelograms. But it's really surprising that this person with this extensive spinal cord abnormality is still able to walk. Yes, they're a little bit myelopathic, but they're functioning well, and we're not really able to do anything effective for those patients. I've got one quick slide about congenital spinal cord disorders, and just to make the point that in this case, there is actually a tethered spinal cord from a spinal cord lipomyelomenincocele with this very large syrinx. The spinal subarachnoid space in these cases is actually completely normal. So there's something about the tethering of the spinal cord that causes the syrinx in these cases. And the best treatment here would be to detether that cord, or if that's not technically feasible, we'll put in a shunt to drain that syrinx fluid. I want to just finish by talking about spinal CSF leaks, because this is a pretty rapidly evolving field, and you may not have come across too many patients with this. There's been now a fairly clear understanding of the different types of spinal CSF leaks. So what I'm talking about here is patients who develop a spontaneous loss of CSF out of the spine, sometimes directly out through a dural tear. And this is shown here in what's called type 1 leaks. And that's usually caused by an osteophyte, a bony spur in the spine that penetrates through the dura. And often that happens when patients have some sort of sudden, not particularly traumatic incident. So commonly I see patients where they've been working out at the gym and they try some particularly strenuous maneuver. The osteophyte punches through the dura and they leak CSF, not to the outside world, obviously, but internally. And then what happens is the CSF pressure throughout the spine and the head is reduced, and the person suffers from intracranial hypotension. And I don't want to go through this in detail, but just to say that there are different types of leak, the most obvious being that puncture through the dura. But there's another type that's only been recognized within the last 10 years. And if I take you back to that CSF physiology section, remember I said that in the spine, CSF is absorbed into veins. Well, that is the anatomical substrate for what is now termed a CSF to venous fistula. And what we think happens is that those veins can enlarge and open up, and CSF basically drains directly into the veins. And that also lowers the intracranial pressure. So we would still call that a CSF leak, although it's technically a fistula. The CSF is being reabsorbed into the circulation, but it lowers the intracranial pressure. And the problem with that is that patients get headache whenever they stand up. So lying down, completely normal, asymptomatic. But as soon as they stand up, or sometimes it takes a little while after they stand up, they get a headache, very much like a hangover. And it's caused by the brain sagging away from the skull. It can actually cause subdural hematomas and other consequences like that. But clinically, they present with the headache, often with what might be called brain fog or impaired cognition, and very commonly hearing changes. So people will say that when they stand up, their hearing sounds muffled, or there might be a high pitch or a change of tinnitus. The classic thing, though, is that orthostatic headache. There's almost nothing else that gives that headache that comes on when people stand up and goes away when they lie down. So if someone presents with that type of headache, you've really got to think about spinal CSF leak as the underlying cause. Can be very difficult to diagnose. So these are pretty extreme examples. So this is just a patient with intracranial hypotension, and what's happened here is that the brainstem, this is the pons, that's the midbrain, they would all normally be about 2 centimeters higher up. So this is really severe distortion of the brainstem. It's sagging right down through the foramen magnum. And it's no wonder that these patients get cognitive disturbance as well as the headache. It can actually sometimes be so severe that people are unconscious. As soon as if they sit up, they become unconscious, and they lie down, they regain consciousness. It can be that severe. This is a classical imaging finding where there's contrast enhancement, technically called pachymeningeal contrast enhancement, where the meninges, because they become inflamed with the traction of everything falling away from the dura, becomes inflamed, and that becomes contrast enhancing. Or people get chronic subdural hematomas. Chronic subdural hematomas are very common in elderly patients, and so a unilateral chronic subdural wouldn't raise suspicion of a CSF leak. But in a younger person, sometimes 40s, even 50s, with bilateral chronic subdural hematoma without any previous trauma, should raise suspicion about intracranial hypotension related to spinal CSF leak. So finding the leak can be very difficult. Here's some examples. So this is a myelogram where contrast has been injected into the subarachnoid space, and this demonstrates leakage of that contrast into the extradural space. Typically, as I said, it's caused by an osteophyte. They're very subtle. That's the osteophyte here that's the cause of a dural penetration and CSF leak in that patient. This is what we call a digital subtraction myelogram, where we do a dynamic myelogram. And what this is demonstrating is a CSF to venous fistula. So here's the contrast running up the spine, coming out into a nerve root, and then it enters a vein and comes down into the vein. So this is a really enormous, rapid CSF to venous fistula, where CSF is going directly into the vein and causing intracranial hypotension. This is just showing how we do that. This is a hole, this is the spinal cord, and here I'm coming from a posterior approach, going around the spinal cord and sewing up that ventral dural defect that's caused by an osteophyte. So we can do that by approaching the spine from posteriorly, because we get an angle like this, and we can get to the midline in front of the spinal cord and either sew up or plug the dural defect using muscle patches or different types of glue. The whole idea, of course, is to repair that dural defect and stop the CSF leak. And this is just an example of a nerve root. That's a spinal dura. That's arachnoid that's herniated out through a spinal nerve root. And underneath that is a hole in the dura that's probably caused by a patient with a connective tissue disorder like Ehlers-Danlos syndrome, where they've got weak collagen. They get a dural defect, the arachnoid herniates out, and then it bursts and they get a CSF leak. So here I'm just sewing up that dural defect to close that hole. So I wanted to just finish by thanking you for attention, but pointing out that the CSF group at Macquarie does basic science research, clinical research, and we have a multidisciplinary team. And just like to thank our sources of funding and the big team that has been involved in CSF research at the university over the last couple of decades. So thanks for your attention.
Thank you so much, Marcus. That was so fascinating. And seeing all those videos of surgery, it's not something we get to see in general practice much at all. And now I'm also just recalling all my patients with headache and brain fog that I need to maybe call back in and talk to them, maybe figure out what's actually really going on. But thank you so much. Now we might have 1 or 2 minutes to answer any questions. If anybody has any questions for the chat box, you can put those in there. We have some
questions there I could answer.
Oh yeah, do you see those? Yeah.
Yeah. So the first question is really very important, because again, if you think back to how we were taught a syrinx causes sensory deficits, it would have to be bilateral, because we were kind of taught that it was a central cord thing. It was getting the crossing spinothalamic fibers. But that's not the case. It's been shown that it's actually where the syrinx dissects into the spinal cord, usually into one of the dorsal horns, but it can go on both sides. So if it's on both sides, the person will have bilateral sensory loss. But if it's on one side, it can just be unilateral. So and I'd say it's probably about 50-50. Patients will pretty commonly have unilateral sensory loss. And then the second question is, if you get collapse of the syrinx, do they get clinical improvement? It depends. What I tell patients is that the syrinx rupturing or dissecting through the cord tissue has damaged the cord structure, and that my job is to get the syrinx collapsed so that it's not causing more damage. And then when we get it collapsed, whether there's recovery of function depends on how bad the damage has been to the cord tissue, and we can't really tell that. And unfortunately, sometimes I think there's some recovery of function, and that's manifested as a worsening of pain. When that happens, it usually gets better over a year or two, but it is, it's an unfortunate sequel that sometimes we see that.
Thank you so much for that. We might move on now with Dr. Brian Shu's presentation, who is going to be speaking to us about pediatric and adult scoliosis. Okay, and with the chat box, if there are some questions throughout the presentation, you can write them in the Q&A chat box, and we can try and answer them along the way as well. Over to you, Brian.
Thank you, Natasha. Good evening, everyone. Thank you for attending and thank you for asking me to present this evening. So what I'm going to talk about, I'm an orthopedic spine surgeon. I do pediatric and adult scoliosis mainly, and I will talk about a little bit about spinal alignment. We'll talk a little bit about what is scoliosis and a little bit about pediatric versus adult scoliosis, which has different presentations and also different implications, because in the pediatric spine, it's a growing spine, and Marcus has alluded to, a lot of things can affect the spine and cause imbalance. So, and therefore create a scoliosis. So what is normal spinal alignment? So when you look at the spine from the back or from the front, it should be essentially straight. We actually don't accept, we don't actually call it scoliosis unless there is 10 degrees by definition, because on any given day, you could be standing with a slight a list, or if you have a little bit of back pain or something, you can have some muscle spasms, so you can have a mild curvature. But unless it's a more than 10 degrees, we don't technically call it a scoliosis. But when you look at the spine from the side, you will see that there is a cervical lordosis. There's also a thoracic kyphosis and a lumbar lordosis. So it's essentially a S shape from the side. And that's what you would see on an X-ray, the curvatures. And we've done a lot of studies more recently in the last 10 to 15 years about what is normal spinal alignment. Now, this will apply more to the adult spine when we will talk about it a little bit later. But in terms of scoliosis, this is exactly what you see on the picture on the right, is a curvature that is a side-to-side curve, which is what we call scoliosis. The way we measure it is that we find the most tilted vertebra at the top and the most tilted vertebra at the end, and we measure that angle in between. And you can see that it's not just a simple side-to-side tilt. There is actually also a three-dimensional component, which is the rotation of the vertebrae. So you can see on these X-rays, on the axial CT scan, the spine is actually rotated. Therefore, the ribs on one side would be elevated because of that rotation. And this is part of the research that's going on, and Marcus has mentioned that when there is muscle imbalance and when there is even some slight imbalance, even particularly in the growing spine, that column of the spine, which is inherently very unstable, because it really just blocks of bones sitting on top of each other, and it requires the muscles and an intact nervous system to keep it balanced. And if something tilts it into imbalance, and then basically that column twists and then starts to bend, and it starts to collapse. And there's different types of scoliosis. There's the idiopathic type, which is the ones that we see particularly in adolescents, but we don't necessarily find any cause for it. That's why we call it idiopathic. However, there is the neuromuscular type, which is the ones that Marcus mentioned with the Syringomyelia, plus, the other types that could be involved with a syndrome or cerebral palsy, Duchenne's muscular dystrophy. There's a whole range of pediatric conditions that can give you scoliosis. And of course, there's the congenital scoliosis, which is an actual developmental error in the spine, where there's actually more growth plates on one side compared to the other, which causes a growth imbalance. So what are the things that are not truly scoliosis? These are the words that we tend to use to describe some of the scoliosis that we see on X-ray being not a true scoliosis. So when someone has pain, they often stand with a list and a lean to one side, and there's not a true rotation of the spine. And so that we call that a sciatic or pain-related or postural scoliosis, or we would also call it a non-structural scoliosis, or sometimes a compensatory scoliosis. If someone has a leg length discrepancy, if the pelvis is tilted, you will naturally have a compensated scoliosis because of that pelvic tilt. So that's also not what we call a structural scoliosis. So there's quite a few things to exclude before we label something or diagnose something as truly a scoliosis. But one of the key points is, on the AP view, you would have 10 degrees before we call it scoliosis. And the key point, it is three-dimensional, and there's a rotation to it. The difference between pediatric and adult scoliosis, besides the age of the patient, is that in the pediatric scoliosis, the spine is growing. So part of the assessment of the patient is about the growth history and the growth projection of that patient. There's also a significant part of that assessment regarding the family history, because a lot of it is genetically related as well. So if you have a first-degree relative, like your mother, having scoliosis, so you have a much greater chance of having scoliosis in her offspring and her children. And in adult degenerative scoliosis, it's somewhat a different type of scoliosis. They're still collapsing curves. They are often related with a lot more symptoms of back pain or spinal stenosis or leg pain. There is a significant change in their sagittal alignment, which is the S-shaped curve that you see looking from the side, and also a lot to do with their pelvic alignment, mainly because of wear and tear and collapsing of their discs. So this particular slide is just to illustrate that there is a much higher risk of a female having an adolescent idiopathic scoliosis than male. So one of the reasons we actually screen or send a male patient for an MRI scan much more readily, because of the high difference in between male and female distribution. So when you take history of scoliosis, what we look for is, firstly, we ask how the curve was detected. We ask whether there is any pain, because generally scoliosis is not related to pain. So when there are history of pain, we look at it in a different light. We ask about neurological symptoms, respiratory symptoms, family history, and also the status of growth. In a female, we would ask about the age when they start their periods, but also other questions that you would ask relating to growth history, how, whether their shoe sizes are changing, whether they've gone through a growth spurt, and a few other different assessments in terms of age. So the diagnosis is usually suspected by some sort of body asymmetry, whether there's an uneven shoulder, maybe there's a prominence in their scapula, and sometimes there is a difference in their waist from one side to the other, depending on where the scoliosis is. And obviously, a neurologic examination is essential. This is a quintessential test, because this Adams test, when you bend the spine forward, it shows you the three-dimensional or the rotation of the spine. So this is key. The structural scoliosis, as I said before, is almost always related to a rotation, and therefore the Adams bend test shows you that difference in the rib hump, or the difference in the height of the ribs from one side to the other. And that makes the diagnosis of a structural scoliosis. So one of the key things in terms of assessing adolescent idiopathic scoliosis or scoliosis in the growing spine is the assessment of the skeletal growth, how to assess how much growth that the patient still has, and then what's the risk of the progression of their scoliosis. So the things that we use we use such as parental height, how tall is the child compared to the parents. We use growth charts, we use serial measurements. We check for when they start their periods, if they're female. We know that approximately when they start the periods, their peak growth velocity is approximately 1 year prior. And also they have approximately 18 to 20 months of growth remaining, even though it's starting to slow. So that's also one way that we estimate the amount of growth. Family history, as I mentioned before, is also important. One of the most important things is their age of presentation. If their age of presentation is less than 10 years, we now classify it as early onset. And one of the reasons is because you can have very rapid growth once you hit double-digit age of 10. And if you already start with a 20 or 30 or 40-degree curve, then that would certainly become quite a large curve when you're in your early teens. Bone age, that's one other way we try and estimate how much growth a child may have. And there are radiological studies that look at the growth plates in the hand and estimate how much growth or what the bone age is compared to the chronological age. One of the things that we use very, very commonly on the X-ray, and that's why we like to get full-length X-rays that include the top of the pelvis, because there is a particular growth plate on top of the pelvis, and we call that the Risser sign, and that's the apophysis that grows on top of the iliac crest. That grows usually from lateral to medial, and depending on which stage it is, it tells us how much growth the child still has. The other reason the other X-ray sign that we use is the triradiate cartilage in the hip. And that's the other reason why we like to have full-length X-rays that include the hip, because that gives us a clue. If the triradiate cartilage is still open, there is a lot of growth remaining. Other bone age measurements include the olecranon and also the proximal humerus as well. And there's also a study I've done that try and assess the risk of the curve. But essentially, this is the key. This is the key table where if the child presents at age 10 or 12, and the curve is around 20 or so degrees, there is already a 60% chance, more than 50% chance of a progression of that curve. So the earlier the child has scoliosis or detected to have scoliosis, the more important that it is that we keep following it. It doesn't mean that they'll progress to a stage that we'll need to do any treatment. But the earlier the child has seen or discovered to have scoliosis, the more important it is that we continue to monitor it. So what other curves are more likely to progress? Curves in females, curves in patients that are a lot younger, patients who are skeletally immature, or using either the Risser sign or some of the other signs that we use on X-ray, and also if they are sexually immature, meaning that their sexual development or they're premenarchal, meaning that they still haven't had the periods yet. In the thoracic spine, curves that are less than 30 degrees usually show no further progression when they finish growing. However, curves that reach 50 degrees, they tend to progress even after skeletal maturity. That is why we tend to recommend treatment earlier, and particularly in curves that reach 50 degrees. In the lumbar spine, it's slightly different. The lumbar spine is a lot more mobile and tends to progress a little bit more. Curves less than 30 degrees, we still accept that most of them will not cause any problems. But once they reach 35, 40 degrees, we start to worry because they tend to progress more because of the mobility of the lumbar spine compared to the thoracic spine because of the ribs. Now, genetics, I mentioned before, if both your parents have scoliosis, you probably have an 80% chance. If you have one sister, probably a single-digit percentage chance. But certainly, if you have if your mother has scoliosis, then you have roughly about a 10% chance higher than the general population. So these are things we usually look at when a child comes to see me. We always check the siblings if they're there, and we check the parents to see if there is a family history that they may not have noticed before. So key points are: younger the patient, the higher risk of progression, so need to monitor them, radiologically earlier. We estimate their maturity, and we usually like full spine x-rays, basically because we can assess their maturity much easier when we can see their hips and the top of their scoliosis. So what is the natural history of scoliosis? Why do we need to treat them? Well, it's not because of back pain. Natural history of scoliosis does not give you a higher incidence of back pain than the general population. However, if curves are left to progress to a high degree, you can get cardiopulmonary dysfunction, particularly in the thoracic spine. So once you reach around 60 degrees, you start to have some limitation of respiratory function. And if you reach 80 degrees or more, you can actually have heart failure due to cor pulmonale, or the heart having to pump extra hard to get your blood circulated through your lungs. So there is an increased mortality if the curve is over 100 degrees, and thankfully we don't see those very much anymore. The other problem that we also often see is that patients would present with a concern about their appearance or cosmesis. And the psychosocial effects of scoliosis is actually not very well recorded, but it's actually with some of our measuring instruments and questionnaires, we are detecting more and more of significant concern. A lot of the patients come and they actually complain of discomfort or pain, but when you actually ask them in more detail, what they're actually worried about is the cosmetic concern. So what do we do with treatment in pediatric scoliosis? Well, it depends on how big the curve is, depends on how much growth the child still has. Less than 20 degrees, we generally just observe with further x-rays. More than 45 degrees or more towards 50 degrees, and if the child still has growth, or if they reach 50 degrees, we would tend to recommend surgery, because we know that curves that are 50 degrees or more, even at skeletal maturity, it will continue to progress even into adulthood. So over 40 degrees, we tend to start discussing surgery, but generally we tend to operate around 50 degrees or more. One of the non-surgical types of treatment that we use is a brace, what we call a thoracolumbar orthosis, and it's a molded plastic brace. The other type of brace, called the Milwaukee brace, is for curves that are higher up in the thoracic spine, and it's been notoriously difficult for adolescents to wear because of the appearance of it and the cumbersome wearing that brace and taking it on and off. So the Boston brace, which the TLSO, gives a passive sort of correction for the curve, particularly in the growing spine. We don't tend to prescribe braces in the mature spine because there's no further growth. But the idea of the brace is that in the growing spine, if we apply some passive correction, there is about a 60 or 70% chance that we can stop progression, or at least slow progression, and keep the curve under that 50 degrees or 45 degrees. Exercise has also been described, and while there's no clear studies that show that exercise will prevent scoliosis or correct scoliosis, we do recommend exercise to maintain flexibility. So I'm going to put up a poll question just to make sure you're still awake and this is a question about the 11-year-old female that presents with a 30-degree scoliosis. She hasn't had the periods yet, and she's shorter than her parents and her 12-year-old sister. How should she be managed? What do you think? So shall we show the results? And the answer to this is to refer for bracing and X-rays. We wouldn't review in 12 months because that may be too late, because she has a 30-degree scoliosis. If she is growing, which is likely she is, because she is premenarchal, then the curve will likely reach 40 degrees or 45 degrees, which means that you missed a chance of bracing. So referring early at this point and treating it with a brace is probably the only option at this point, and that would be the correct answer to the whole question. Now, surgical treatment, I'll run through this very quickly. There are different types of surgical treatment. There's fusion and non-fusion. The non-fusion type is when we put a device in to allow the spine to continue to grow, and we usually do this in younger children when we still need them to grow significantly, particularly when the lungs are not developed yet. Usually that means before the age of 8. And some of these devices, we continue to lengthen them, either with further surgery to lengthen the rods, or sometimes magnetically lengthen them with a big magnet that we put on their skin, which has been very useful in avoiding further surgery. We also have techniques where it's still early days and it's still under evaluation, where we essentially tether one side of the spine and allow the other side of the spine to grow and try and balance that scoliosis out, and therefore we can avoid a fusion. There are downsides to that, because generally the cosmesis or the correction in terms of the rib hump isn't quite as good. So some people have been narrowing the indications and avoiding that in some patients. And of course, there is a traditional fusion, which we've been doing since the 1940s and 50s. Now, I'll run through adult scoliosis fairly quickly because of time. Most of these adult scoliosis are due to wear and tear, arthritis, and depending on the degree of the curve and depending on the patient's symptoms, the treatment will be different. So something large curve such as this, the patient would often have pain not just from the arthritis or spinal stenosis, but what we call a rib-on pelvis deformity. You can see on the left side where that rib is starting to touch the brim of the pelvis. They often have a collapsing scoliosis that causes symptoms beyond the intrinsic arthritis and wear and tear of the spine. And a lot of this adult scoliosis initially is managing of their symptoms related to the degeneration, such as spinal stenosis. We often do exercise, injections, pain management, until the point where they've lost their balance so much, or their pain has become so much that it's unmanageable, that we would consider treating it with surgery. And often it is the spinal degeneration leading to loss of stability, integrity of the spine, causing some degree of scoliosis, and over time that progresses into a larger and larger curve. So the key point here is just with adult back pain, it can be associated with scoliosis, and degenerative scoliosis usually progresses with time and also with age. And we often obtain a standing full spine X-ray to assess the scoliosis and also assess the sagittal balance, which is the stooped posture that some of them can develop because of the wearing out of some of their discs. I am going to stop there, Natasha, and maybe answer some questions, because I think we only have 5 minutes left.
That would be great, Brian. Thank you so much for that presentation. It's so interesting and learning so much about this topic. It's great. Somebody asked, where do patients get the braces and who does the counseling?
So at the Children's Hospital, we have orthotists that make the braces, and we do the counseling along with the orthotist in terms of counseling how we wear it, how they wear it. They have to wear the brace 20 hours out of 24. So it's an undertaking. It's certainly not built for comfort, but unfortunately, there's nothing else between observation and surgery that has been shown to work.
Okay, great, thank you. And then in children, what degree of scoliosis in terms of the Cobb's angle would you refer? At what degree?
So depending on the age of the child, the younger the child, even if it's a 20-degree curve, I would refer early. Because, like I said, if it's an early onset scoliosis, we need to monitor it very closely. On the other hand, if it's a 14-year-old, 15-year-old, 16-year-old, which are mostly skeletal immature or close to it, a 20-degree curve probably doesn't matter. But that provides that is provided that we're measuring the curve correctly, because I have seen many X-ray reports of measured curves that are not what it is.
Yeah, getting a second opinion from a specialist is, I'm sure, very important. In a patient who, say, has just a small degree of rotation, like this attendees, like say 7 degrees of rotation, but they still have symptoms of pain. What do you do for these symptoms?
So I investigate the pain completely separate to the scoliosis, because as a general rule, scoliosis does not cause pain. So it's much more important to investigate, particularly a child. Children don't usually complain about back pain, particularly if it's more than a couple of weeks, the back pain, we investigate. Okay. So, because occasionally you pick up something completely different.
That's good to know. And what about kyphosis and scoliosis happening together?
So kyphosis and scoliosis can often happen together, particularly in quite severe scoliosis. And kyphosis scoliosis is where the scoliosis is so severe that it twisted and actually becomes a kyphosis. So we treat both as part of the scoliosis and the deformity as general.
Okay, great. I think that might be all the time that we have for today. Thank you again so much, Brian, and thank you, Marcus, for these very riveting presentations. We don't get to learn much of this I think in medical school or in our general practice training, so it's really helpful for us as practitioners to learn how to manage these patients and improve our patient outcomes, because we are seeing a lot of these patients. Serena, are you happy to take over?
Yep, thank you.
Okay, thanks.
I would like to extend my thanks to Marcus, Brian, and Natasha for presenting this evening, and also to everyone who joined us online. We do hope you enjoyed the session and you also enjoy the rest of your evening. On another note, a friendly reminder that this is a CPD activity, so to receive your CPD hours, you need to complete the survey that follows the webinar. Once the webinar ends, you will automatically be redirected to complete the survey. We will also include the link to the survey in the following email that you will receive tomorrow morning. Whenever you choose to do the survey, you only need to complete it once. That brings us to the end of the session. Thank you and good night, everyone.